Okay, so now the next topic after looking at labs for various bone disorders is to look at primary versus secondary bone tumors. Metastatic disease is obviously more common than primary bone tumors. One that we talk about quite often is prostate cancer metastasizing to the spine. Over here, they tell you also a pathology thing, right? So benign bone tumors that start with an O are more common in boys, and that's a pretty nice way of remembering it. And we're going to see all the ones that start with an O, they have the red O, right? So all the ones that start with an O are much more common in boys. Not the most relevant information, but it's information nonetheless. So the way these cancers are named is a pretty big deal that you learn a little more about in pathoma. But basically, if it's a chondroma, right, then it's more cartilage based. Otherwise, it can be osteoid based, and then the rest of them are pretty well named. So it could be based off of a cell type, like um, the various osteoblasts and osteoclasts, right? So we're going to see a lot of that. So you have chondro again, osteogenic again. So this one here, this is an osteoblast based one. This one's osteoclast based one. And then of course the malignant ones are going to have sarcoma in the name, so that's going to be there as well. And you learn about that in pathology and first aid as well, but you learn much more about that in pathoma if you want to. So, going down the list, first one is an osteochondroma. That's just a cartilage-based one. It happens in the metaphysis of long bones, so it's really important to remember what the different parts of the bone are called, right? So this bottom part here is the epiphysis, the middle portion is the metaphysis, and then the whole thing is the diaphysis, right? So really important to know the location of a tumor to be able to classify what kind of tumor it is. Osteochondromas are found in the metaphysis of long bones, and they usually have a cap. So I always thought about osteochondroma as like an osteocap, right? Imagine a younger man wearing a cap. You know it's not a young boy because it starts with no, and caps are a pretty common thing on young boys. So lateral bony projection of growth plate continuous with the marrow space, covered by a cartilaginous cap, and it's usually very prominent, so it's really easy to see. And this is what they're talking about: something sticking out with the cap on it. So something like that. So osteochondromas are pretty different from the others, and they're definitely something you can identify just by looking at them. Osteoma is found on the surface of facial bones. This is very different from the other ones. You're not going to see any other bone tumor here on this list that you actually find on facial bones. And this guy is actually associated with Gardner syndrome. So when we were in GIT, we saw Gardner syndrome, and we said cover your eyes and teeth and guard yourself. This was related to familial adenomatous polyposis, where you have polyps throughout the colon, and the rectum is always involved, right? So this is little information you have to know. So this is on page 420. So let's take a look at it. So on 420 we talked about colonic polyposis, page 381 of the first aid itself. And at the bottom they talk about polyposis syndromes, the first one being FAP, familial adenomatous polyposis. Autosomal dominant, APC tumor suppressor, right? So it has a 2-hit, both of them have to stop working, and then you can't suppress it anymore. Chromosome 5 is involved, and it's pancolonic, so it's the whole colon, and it always involves the rectum, right? So you have to get rid of the whole colon, otherwise there's a 100% chance it will go to colorectal cancer. And there was Gardner and Turcotte, which were two different variations of extra stuff along with the FAP. Gardner was the one with the osseous and soft tissue tumors, osteomas of the skull or mandible, right? And then congenital hypertrophy of retinal pigments. So that's why the eye was involved, and impacted supernumerary teeth. Right? So we made up this thing here: guard yourself with your bones, close your eyes, and prevent impact to teeth. Turcotte is the other one that has to do with CNS tumors. So Turcotte for turban. So that's your osteoma right there, right? So associated with Gardner syndrome. An osteoid osteoma, right? This one is going to be compared to your osteoblastoma, right? So an osteoid osteoma is more osteoid based, and this one occurs in the cortex of long bones. It presents as bone pain, which is usually worse at night when you're laying, and it's relieved by NSAIDs. So at least that's good, right? It's a bony mass that's pretty small, and it has a radiolucent osteoid core. So if we look at image B, you can see right here, right, this is the cortex. It has a radiolucent core right here. Right, so this entire thing right here. So not always going to be the easiest thing to identify, to be honest, in the sense that if I give you Here what they did on this x-ray is they zoomed in onto it. But if it was the whole leg, right, then it's a little harder to make sure you can see that. But always look for weird things like this, right? This is literally like a hole punch in the bone. That's a giveaway for osteoma right there. And NSAIDs will help. Compare that to an osteoblastoma. This has similar histology to an osteoarthritis, but it's larger in size physically, and the pain is unresponsive to NSAIDs. The location is different too. An osteoblastoma will usually be in the vertebrae. All right, it's really significant stuff here. These two guys are pretty often compared, and you need to spend time actually, either making flashcards or studying with another partner and kind of like memorizing these, right? So if I say osteoma, you should think of facial bones and Gardner syndrome. If I say osteoid osteoma, you should remember NSAIDs help it, and it occurs in the cortex of long bones, and so on and so on. You definitely want to make sure you memorize these pretty well. These are significant enough either for NBME or step 1. A chondroma, again, cartilage related, right, because it starts with chond in it, is a benign tumor of the cartilage. It's really simple, really straightforward, not a big deal. It occurs in the medulla of small bones of the hand and feet. Now, we say it's not a big deal because it won't kill you, but it actually looks really bad. So I think I have a bunch of pictures on the next page. This is a chondroma right here. And so it looks really annoying and really weird, right? Multiple chondromas on the finger, known as Ollier disease and Malfucci syndrome. There's different names for various diseases that actually cause chondroma on the hand. So found all of that on Wikipedia. Really important to go ahead and look up more pictures of any cancer that you see that you can actually find pictures of, because you never know when you might have to actually identify something just based off of description, right? You might not get a picture, but they might describe the picture that I just showed you, and you should be able to paint a picture of something in your own eyes so you can identify it. The last thing on this page is a giant cell tumor, which pretty much is the other cell. So this was osteoblastoma. A giant cell tumor is an osteoclastoma. It's a locally aggressive benign tumor with neoplastic mononuclear cells that express rank ligand and reactive multinucleated osteoclast-like cells, which is why it's called an osteoclastoma. Osteoclasts are very big multinucleated cells. So that kind of, I always visualize a large multinucleated cell full of little baby cells, basically, and it kind of looks like soap bubble. Right, so when the big thing I'm thinking of for an osteoclast is just a really big cell with a bunch of tiny cells in there, right? That's what a multinucleated cell will kind of look like, and that in itself is kind of resembling a bubble, like a big soap bubble, a bunch of little soap things happening, and that works out perfectly for me because an osteoclastoma does have a soap bubble appearance on X-ray, and you can see that right here. Right? You can find even better pictures than this if you look online, but the main thing is this is supposed to be clear like this. There should not be many little lines like what's happening over here. So when you start seeing something like this at the end of a bone like that, that's a sign, right? And you could tell this is in the wrist right here, right? Because you can see the little bones of the wrist bones that we were talking about earlier. Also, we just talked about chondroma earlier. Then on the next page, they have chondrosarcoma, which also affects the medulla of pelvis, proximal femur, and humerus, and it's a tumor of malignant chondrocytes. This one, although low yield, is worth remembering because it's related to chondrocytes, and it's the only malignant one. I haven't really found more online. Right, so this is the only malignant tumor of chondrocytes, right? Whereas a chondroma is a benign tumor of cartilage. But they both affect the medulla of small bones, right? And medulla of small bones for that guy, but here is the medulla of the pelvis and much bigger, heftier bones. So worth remembering. Nothing crazy, but definitely worth remembering. The last two have a bigger deal attached to them. So you have your osteosarcoma and an Ewing sarcoma, and these two are both pretty much malignant because they're sarcomas, right? Your osteosarcoma is an osteogenic sarcoma, so this accounts for 20% of primary bone cancers, which is one of many reasons you should definitely make sure you remember this. The peak incidence of primary tumors are in males that are under age 20. Less common in elderly, usually secondary to predisposing factors such as Paget disease of bone infarcts, radiation, familial retinoblastoma, and Lee-Fromney syndrome. So what's happening is basically any one of these diseases can be the primary aspect of your question, and then your question can shift gears and actually be about an osteosarcoma, so it's totally worth knowing. So far, we've talked about Paget disease of the bone, and that was the first time we saw it, right? We said that the Paget disease of the bone should remind you of the whole Paget mnemonic, and the T in the Paget is for triangle to remind you of the Codman triangle. And so the Codman triangle right here should remind you of this weird projection that you start seeing. This is a picture I put here of the Codman triangle. This is something that's never there, right? You've never seen anything weird happening like this. So the Codman triangle is from the elevation of the periosteum, right? Or you could say it's a sunburst pattern apparently on X-ray. I don't know who comes up with these names. So think of an osteocod, bonefish, swimming in the sun. Honestly, that never worked for me. I just remember Codman triangle every time I think of osteosarcoma, but whatever helps you, go ahead and use that. But as it is, it's a sarcoma, so you're going to see pleomorphic osteoid producing cells, which are basically malignant osteoblasts, and it's very aggressive, right? Thankfully, it is responsive to surgery and chemotherapy, but if it's secondary to something else, if it's secondary to Paget disease of bone or familial retinoblastoma, blah, 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 that has a poor prognosis, all right? So although 20% of primary bone cancers are osteosarcoma, the primary ones are going to be okay. You could do chemotherapy and help them out. If it's secondary to any of these other guys, though, then it's got a poor prognosis. All right. Here in the middle, there's just a histological image I found online. It's showing you sheets of malignant pleomorphic cells with extensive malignant osteoid formation. And if I make it bigger, right, then you can, let me see. Yeah, you can see there's an arrow showing you right here and another arrow here. Basically, all this extra pink stuff in the middle, all the pink stuff in the middle, that is your osteoid formation, right? You're making a lot of osteoid. So there's 1, 2, 3, 4 arrows here just pointing at all this extra osteoid being formed. Other than that, there really isn't anything else to remember here. It's going to be pretty obvious because they're going to do a lot of... First of all, remember that it's often in the knee. Okay, so that's kind of what you're seeing here too. Often in the knee, which, when I look at this, I even think this looks like a knee over here, with this being the patella. It's not. This is just the Codman triangle, but this has the knee formation to it, right? So that hasn't really been too hard for me to remember most times. But most questions about an osteosarcoma will be pretty easy to catch. They're usually going to stem off of one of these other diseases and then lead to a tumor, and you have to recognize that those diseases are related to osteosarcoma. The last guy here is an Ewing sarcoma. This is most common in Caucasians, generally really young boys. You see it in the diaphysis of long bones, especially the femur, and the pelvic flat bones. This guy is unique because you would see this here, homerite rosettes, which is pretty specific to only a handful of things. You'll see anaplastic small blue cells of mesenchymal origin, and they resemble lymphocytes. So they really just look like this, right? Differentiate from conditions with similar morphology like a lymphoma or chronic osteomyelitis by testing for the translocation 1122. There's a translocation associated with this, and it's basically a fusion that makes a fusion protein EWS FLI1. You also see onion skin periosteal reaction in the bone, and they're showing you that here. Right, so I personally don't really see it, but I can tell something's here that shouldn't be there. Right, so something weird is happening. It should continue looking like it does up here. Now there's some kind of weird stuff happening here. This is due to the onion skin periosteal reaction. Aggressive with early metastasis, but responsive to chemotherapy. So that just happens to work out. Now, if you follow basketball, then you remember, Ewing's jersey number is 33. He's a player for the New York. Well, he used to be a player for one of the New York teams, the New York basketball teams. That's what people apparently use to remember 1122. I personally really haven't had much issue remembering that, so I will just remember that. Here, I'm showing you what they're referring to when they talk about the onion skin periosteal reaction. So this starts happening. You can see the onion skinning when you take a cross section, but without the cross section, you can't quite notice the onion skin aspect of things. Okay. So those are basically your cancers of the bone. Now you do have to spend some time memorizing them. You should make a list and look at it every day, make some flashcards, whatever helps you memorize things, but memorize them. There aren't too many, right? And they're pretty easy to differentiate. There's barely any overlap on them. So just spend some time really memorizing them, right? And they are going to be based off of not just the histology, but also the location on the bone, where you find the tumor, and how the tumor itself looks. Right, whether it be the soap bubble stuff, or it be something with a cap, or it's in the middle, in the medulla, right? Or if it's in the metaphysis, epiphysis, diaphysis, you have to know. You really have to figure that out, and then you can go ahead and actually pick an answer choice. All right. I had a question here. Okay, this one. So this one is an AMBOSS question. It says a 52-year-old woman comes to the physician because of lower back pain for 1 week. The pain is constant, severe, and dull in quality. She does not recall any trauma to the area and has not had any urinary or fecal incontinence. She has had 9 kilograms weight loss over the past 6 months. Physical exam shows localized tenderness over the lumbar spine. An X-ray of the spine shows a vertebral compression fracture at the level of L1. Further evaluation of this patient is most likely to show which of the following findings. And the answer was speculated density on mammography. Now, I know there's a lot of words in this question and you might not be seeing how the flow of answers here is, but basically there's a bunch of stuff you're supposed to catch in questions, and AMBOSS has very different question types than it does on than the UWorld question types are. So what's happening here is, first things first, they tell you that she's complaining of lower back pain. That's what she's truly coming in for. And she describes the pain. It's constant, severe, dull, right? She doesn't have any trauma though. And she doesn't have any urinary or fecal incontinence either. So it's not got anything to do with that area. She's had 20 pounds of weight loss over the last 6 months, but we don't see any reason for why, right? When you see someone's losing that much weight over 6 months and they're not really trying to lose weight, that's a sign of cancer, right? Physical exam shows localized tenderness over that lumbar spine. Now, if this was a man who had localized tenderness over the lumbar spine, you would think prostate cancer. But this is a female that's coming in, so automatically switch gears to thinking breast cancer. An X-ray of the spine is showing a vertebral compression fracture, and you start thinking maybe it's osteoporosis, and that was one of the answer choices, but it's not osteoporosis. We're not seeing any reason to really think of osteoporosis besides the fact that she might be postmenopausal. In fact, she most likely is. She's 52, right? So she's got low estrogen, and that puts her at risk of osteoporosis, sure, but there's no reason for her to actually have it as far as we can see in this question. Further evaluation is most likely going to show what? You're going to see something on a mammogram, right? Because she's going to have breast cancer. And that was the answer. Speculated density on mammography. Unexplained weight loss and a pathologic fracture of the vertebra with no history of trauma should raise concern for an underlying malignancy that has affected the spine. Breast cancer is among the most common malignancies that metastasize to the bone, along with lung cancer, thyroid cancer, renal cell cancer, and prostate cancer. Bone metastasis from the breast can have both lytic and blastic features, right? So breaking and making bone. Really important to know that stuff. Obviously, breast cancer is really significant, and so is bone metastasis of it. At the bottom here, I just have a quick note about osteomyelitis. This is more of microbiology related stuff, but since we're in the bone and osteomyelitis is part of the bone, I put this note here. So I wrote that osteomyelitis affects the proximal metaphysis, right? So this beginning portion of the metaphysis right here. Because the metaphyseal blood supply is unique in that the nutrient artery supplying the metaphysis makes a sharp loop before it empties into the sinusoidal spaces where the rate of blood flow is decreased. This creates a medium for bacteria to proliferate and cause cellulitis in the bone marrow. Most flat bones like the acetabulum are not affected by osteomyelitis because they have no blood vessels and are mainly cartilaginous. Right, so if you ever get a question about osteomyelitis and they're asking you what part of the bone would have the most bacterial infection, it would be the metaphysis, right? Because apparently some artery that enters there makes a weird loop and slows down blood flow, allowing bacteria to settle down. So, point worth knowing. In the last video, we talked about Paget disease of the bone, where we looked at these two images. From here on is just a bunch of extra notes on the bone tumors, right? So, what I'm showing you this for is not because you need to know this all, but it's to show you what I did when I was studying for STEPS. So basically, just because I read the list and read what the cancers look like, according to first aid, I'm not going to remember it all. So I did research, I found more pictures, I wrote more notes, and what happens when you do all that is it kind of sticks to you better, right? So like right here, I found more pictures of osteochondroma with the cap thing, with the thing that's sticking out. I even found a thing that's sticking out that didn't really look the same way, but this is an osteochondroma as well. Right, so I'm seeing it on the femur here, which is the most common thing they've been showing you. This one here is on the humerus, right, so you can see it's kind of sticking out, not the same exact way, but it's still sticking out. right? So there's no cap kind of thing happening. This is a cap right here, but this is still an osteochondroma. Over here, you can see this is in the skull. So as soon as you see it on the skull, you should think of that one little word, the osteoma. Right? Radiodense lesion right in the center there, that's your osteoma. This is an osteoid osteoma, the guy that responds to NSAIDs, remember? So this is going to happen in the tibia in this image. We talked about the chondroma, right? Multiple tiny cartilage-based tumors that are just benign but very ugly. This here is your osteoblastoma, right? So you can see the lateral view of the right knee, noted mass in the distal femur with a large radiolucent nidus, right? Osteosarcoma, right here. So you can see this area right here with the sclerotic bone with massive invasion sticking out, right? Osteosarcoma was right here. Right? Osteosarcoma with your Codman triangle, and the fact that it responds, if it's primary, it responds to chemotherapy. So it's nice to find images and make more notes, because when you do that and when you talk about things more and more as if it's your profession, you just know about it and you memorize it a lot better. Last thing, here's a question. A 3-year-old boy from UWorld. A 3-year-old boy is brought to the emergency department because of high fevers and malaise for the last 4 days. His parents say he began limping yesterday and seems to refrain from using his right leg. He has no history of travel or exposure to a person with similar symptoms. Temperature is 103, passive range of motion does not elicit pain, and no joint effusion is seen. However, the patient refuses to bear weight with his right leg. So 3-year-old boy. Scintigraphy is most likely to reveal increased focal radiotracer uptake in what area? And then they listed out different parts of the bone. So he began limping, doesn't want to put weight on it. He's 3 years old. He's got fever and malaise. You know, what's wrong with this guy? Passive range of motion does not elicit pain, nor is there joint effusion. So it's not some kind of infection. You would see radiotracer uptake in the long bone metaphysis. An image describing the progression of hematogenous osteomyelitis was given, but I could not find it online. Hematogenous osteomyelitis affects children, particularly boys, and usually affects the metaphysis of long bones since it contains slow-flowing sinusoidal vasculature that is conductive to microbial passage. Adults don't develop this due to epiphyseal closure. Osteomyelitis may affect flat bones of the skull via contiguous spread of infection from mastoiditis or dental abscess, right? So his temperature being 103 was a huge giveaway, because that throws you away from thinking it's cancer, right? You can't think of cancer and have fever and, you know, a temperature of 103 at the same time, all right? So this was a question about osteomyelitis, for which I have the note here describing that osteomyelitis is found in the proximal metaphysis. It's really important to know that. They don't talk about osteomyelitis in the MSK chapter, but it's relevant, so I brought it up here. All right, so don't always just jump for cancer. Now, on the next page is another comparison similar to what we saw in GIT with ulcerative colitis versus Crohn's disease, right? So ulcerative colitis was your simple inflammation. It was just a colitis. It has a lot going on, but at the end of the day, it was just a colitis. Crohn's disease is an actual disease. It has many more things, even granulomas, fistula formation, a bunch of weird things happening there, right? So here we have a similar thing. Osteoarthritis is just an inflammatory condition. It's just an arthritis. Whereas rheumatoid arthritis is a very specific kind of arthritis. It's not just inflammation, it's autoimmune inflammation. So one is going to be more systemic than the other. So let's take a look at both of them one by one. Osteoarthritis is due to mechanical wear and tear damage that destroys your articular cartilage. Right? So you get a degenerative joint disorder leading to inflammation with inadequate repair. Chondrocytes mediate degradation and the inadequate repair. So it's all due to the chondrocytes and is due to the excessive activity. So you're going to see this in people who have some kind of career where they were doing something repeatedly for a very long time. Right? Predisposing factors are your age, being a female, obesity, or joint trauma. Right? All of these are very significant for osteoarthritis. Presentation, you're going to see pain in weight-bearing joints after use. Right? So things get worse at the end of the day, which makes sense because osteoarthritis is due to wear and tear. Right? You have osteoarthritis because you have too much things that you did with that one bone or whatever, one group of bones. And pain is going to be worse at the end of the day. Improving with rest. You have asymmetric joint involvement, which totally makes sense, right? Symmetric stuff would be a systemic disease if antibodies are causing it. Asymmetric joint involvement basically means it's only in the left hand but not the right hand, and that's because you're only using the left hand maybe. The knee cartilage loss begins medially, causing bow-legged appearance. So basically the cartilage in the knee, the medial portion, so in between the thighs, the medial portion, that's where the cartilage would die out first. And you can kind of see that right here. So that's what they're showing you. The medial cartilage is going to die out first rather than the center. Here you can see though in rheumatoid, the center stuff has died. The medial stuff is okay. Alright, so really pretty significant difference there as well. Joint findings are going to be bone spurs. You're going to see osteophytes, which are bone spurs. Joint space narrowing, some subchondral sclerosis and cysts. Your synovial fluid is not going to have inflammation, so you're just going to see few white blood cells. And then you have these things called Heberden and Bouchard nodules. These nodes are really easy to remember now. The high nodes are the ones that are at the DIP area, right? So distal interphalangeal joints. The Bouchard nodes are the below ones, so just below it at the proximal interphalangeal joints. Right? And these guys make sense because imagine your hand, imagine you're like a construction worker that's just using a screwdriver all day for some weird reason because drill machines exist now, but whatever. And you're just doing this all day, all day, all day. So you're moving all of these interphalangeal joints doing this construction work all day, whatever the work might be, right? And the other thing that gets involved is your first carpal metacarpal joint. So you can see the first CMC right here is also going to be involved, which is related to your thumb basically, but not the MCP, not the metacarpal phalangeal joint. All right, so your CMC stuff are here, your MCP stuff are here. The MCP is not involved at all in your osteoarthritis. All right, so treatment is just going to be activity modification, obviously a lot more rest, warming it up. There's a bunch of non-medicinal things that you can do for osteoarthritis, and then anti-inflammatory medication. Really straightforward stuff. When you look at rheumatoid arthritis, it's a little more complicated. This thing is actually autoimmune. So it's autoimmune inflammation inducing the formation of pannus, which is proliferative granulation tissue. And that inflammatory pannus actually erodes articular cartilage and bone. So you're really having inflammation, and that inflammation is making more things that cause more erosion. So that's just complete destruction right there. It's going to be related to females who have HLA-DR4, and smoking is actually also a risk factor for rheumatoid arthritis. What you note here is a positive rheumatoid factor, which is an IgM antibody that targets the IgG-Fc region. This is found in 80% of people. But the more specific thing to rheumatoid arthritis, because you can find rheumatoid factor in other diseases too, and we're going to see that as we go on, but the more specific thing to rheumatoid arthritis is your anti-cyclic citrullinated peptide antibody. All right, so antibodies against CCP, cyclic citrullinated peptide. That, when you see those antibodies, that's when you know for sure it is definitely rheumatoid arthritis. All right, so predisposing factors, what I wanted to look at is there's this UWorld question here. This one said, what is the most significant risk factor for osteoarthritis? And then the answer choices were age, cold temperature, family history, sex, smoking, or weight-bearing exercises. And the answer was age. And this was actually, in my opinion, a very difficult question because when you're doing step one, when you're answering questions one after the other, and you see something like this, you immediately start thinking, wow, all of these seem pretty relevant, right? And then when you see smoking as an answer choice, as medical students, we're almost conditioned into picking smoking as a risk factor or a no-no for almost anything. However, smoking is not related to osteoarthritis. Right? Smoking, as we just saw, is more so related to rheumatoid arthritis. Right? Smoking is related to rheumatoid arthritis as a risk factor. But the age, the cold temperatures, right, weight-bearing exercise, a lot of these also seem like things that are related to osteoarthritis. However, weight-bearing exercise would probably be something that would help you not get osteoarthritis, right? Because you've been working out, and weight-bearing exercises we saw in the last video when we were talking about osteoporosis, that it's a good thing. It's a protective thing. It's prophylactic to protect you from bone damage later on when you get older. So the correct answer here was age, which completely falls into place when you think about the fact that osteoarthritis is due to wear and tear. And as you're getting older, you're getting much more worn and torn. All right. So it just falls into place. It makes complete sense when you think about it like that. That's why age is the answer here for the most significant. The most significant. A lot of these other things are risk factors too, but age is the most significant risk factor for osteoarthritis. Right? And then I wrote at the bottom also one more thing. Joint trauma, just like smoking is the unique thing here related to rheumatoid arthritis between the two. Joint trauma, such as injury to the scaphoid bone from a fall, can predispose to OA of the joint. This is one major predisposing factor that is different between OA and RA. Alright? So joint trauma is more of an osteoarthritis thing, whereas smoking is more of a rheumatoid arthritis thing. It's really important to keep those differences in mind. The presentation of rheumatoid arthritis is going to start with pain and swelling and a morning stiffness. So this is going to be bad to begin with. You're going to wake up with stiffness, and this gets better the more you start putting it into action, right? Improving with use. Symmetric joint involvement, because it's systemic, it's antibody mediated, so antibodies are going to be in both hands at the same exact time, same exact flow. And then the unique thing here compared to osteoarthritis, because rheumatoid is autoimmune, there are some extra-articular manifestations, so things that aren't exactly completely related to bone, and we're going to get to that later on. The joint findings here, the difference, so remember here we said the H and B stuff, right? So we have the involvement of these really tiny joints at the top because you're using your fingers for a lot of work. Here in rheumatoid, you're not affecting those guys, right? So it involves the MCP and PIP, right? But it does not involve the DIP, the very distal one. The distal one is not involved at all. The PIP is, and that's okay, because this is actually a really big joint compared to the very distal one. This is also very significant. You need to use it. The last one is not involved though. The DIP is not involved in rheumatoid arthritis, and that's very important to remember. That fact alone can actually help you differentiate between one disease over the other. Right? If the question tells you the DIP is involved, you can actually go ahead and just really think it must be osteoarthritis. You know, unless something else is there to really throw you off again, DIP involvement, you go with osteoarthritis. If the involvement is with the first CMC, wait, what am I saying? The MCP, right? Because remember the MCP was not involved at all, right? This MCP was not involved at all when we were doing osteoarthritis, right? There was nothing happening to your metacarpophalangeal joints, which is right here, right here. This portion was not involved at all in osteoarthritis, but it's involved here in rheumatoid, right? This one and the one after that. These two guys are very much so involved in rheumatoid arthritis, but not in osteoarthritis. Osteoarthritis was only looking at the very far two guys, the very far two points where you bend your fingers, right? But in rheumatoid arthritis, you're looking at the part where you actually start bending your finger first, and then the second part too. Right? So that's that stuff here that they're talking about for joint findings is basically your physical exam findings. That's really going to help you differentiate between one over the other. So definitely spend some time making sure you get it, right? Making sure you memorize it and really understand why it is the way it is. Now, why it is the way it is for rheumatoid arthritis, there's no really a way of understanding it. It's more so the fact that it's just how it is because it's autoimmune and that's where the antibodies are kind of going. But the special thing is it's symmetric here, right, in rheumatoid. In osteoarthritis, it does not have to be symmetric because it's not due to something in your blood. It's due to how much you're using that bone. And you don't have to necessarily use bones of the same thing on both sides of your body, right? But the distal two things are involved, the DIP and the PIP for osteoarthritis. Whereas in rheumatoid, it's just the PIP and the MCP, okay? So very significant, the DIP versus the MCP stuff. DIP is for osteo, MCP is for rheumatoid. Now, here you have a couple more medications, right? You have something called disease-modifying agents, right? And there was a note in URL, so they tell you for rheumatoid arthritis, the disease-modifying anti-rheumatic drugs, or DMARDs, reduce long-term joint destruction and take more than 6 weeks to actually kick in. Short-term treatment with glucocorticoids or NSAIDs can provide rapid temporary relief before the DMARDs actually kick in. Glucocorticoids can be more effective than NSAIDs. Right? So really important to remember these tiny facts. So if a patient is put on any DMARD like methotrexate, leflunomide, any of these guys, hydroxychloroquine, then you have to also give them NSAIDs just for the beginning part, or glucocorticoids in the beginning, just to make sure they're all right until the hydroxychloroquine or methotrexate kicks in. Earlier we said that rheumatoid has some extra-articular manifestations, right? So that's right here. Mainly, you want to think of Kaplan and Felty syndrome. These two show up on NBMEs a lot, and they can definitely be on your step 1. So these extra-articular manifestations include rheumatoid nodules, which are fibrinoid necrosis with palisading histiocytes. And remember, fibrinoid necrosis was related to blood vessels, right? So if you see fibrinoid necrosis with palisading histiocytes, you want to think of rheumatoid arthritis. This is a rheumatoid nodule in the subcutaneous tissue, or you can have extra-articular manifestation in the lung. Right? So pneumoconiosis, that's going to be your Kaplan syndrome. Interstitial lung disease, right? That's really something right there, right? Because this is now you're seeing lung involvement with a bone disease. And it's not lung cancer, it's just interstitial lung disease. Pleuritis, pericarditis, it can even affect your heart. You can definitely get anemia or chronic disease, which we talked about when we did heme and onc. If you have neutropenia and splenomegaly, right, neutropenia and splenomegaly, that is your Felty syndrome. I saw this on an NBME, I think it was NBME 20. They talk about Felty syndrome. You don't need to know the Felty syndrome is the disease, but the patient they describe actually has Felty syndrome, and then they ask a question about something else. AA amyloidosis, Sjogren's syndrome, scleritis, and of course carpal tunnel syndrome. All right. And then the pictures here just go ahead and show you a lot more about exactly what's happening. Right. So you can see in osteoarthritis, the bones that are mainly involved, whereas your rheumatoid arthritis, you have the other big joints that are involved. Right. So you see the ankle involvement is different, elbow involvement is different, right? Wrist involvement is different. Those are the really big areas that you commonly use but are different between the two. These pictures at the bottom are also very nice. You can get one of these images like this to kind of get you to pick an answer. Now any of these two guys, right, the swan neck and the boutonniere, these two are always going to be rheumatoid arthritis. There is no such thing like this for osteoarthritis. This is a disease thing. Alright, and the distal interphalangeal joints are okay for these guys. The DIP is actually okay. The issue is before the DIP in these guys, because rheumatoid arthritis, it doesn't affect the DIP. But you can see in the first two finger pictures, you're seeing nodules in the DIP. Right? So when you start seeing something occurring in the DIP, this guy has it too. He has nodules in the DIP. But he also has massive, very noticeable nodules in the PIP. Right? So Hebron is high nodules. Nodules are the highest part. And Bouchard is the below it, in the middle. Alright, so that's your osteoarthritis stuff. This is just showing you granulation tissue, which was related to rheumatoid arthritis, pannus formation, remember. And that pannus formation is really significant. This pannus is going to go ahead and erode more articular cartilage, so that really sucks. We have a URL question at the top. It says, a 47-year-old woman comes to the physician with progressive joint pain and swelling in her hands for the past several months. She also has fatigability that has gradually worsened over the same period. Morning activities are especially difficult due to stiffness lasting 1 to 2 hours after walking. Examination shows warmth, swelling, and tenderness involving the PIP joints, MCP joints, and wrists bilaterally. A blood sample is obtained for lab analysis, autoantibodies against what is most specific for her condition. And it's the CCP stuff, right? Citrulline peptides, or more specifically, the cyclic citrulline peptide antibodies. You could tell this is rheumatoid arthritis from the beginning. First thing they tell you is that she has morning stiffness, right? Morning activities are hard due to stiffness, lasting 1 to 2 hours. So it gets better though. It gets better when she starts walking. All right, once she's walking, it disappears after 1 to 2 hours. And then they also tell you there's involvement of the MCP. Right? And the MCP involvement is rheumatoid arthritis specific. That's really all there is to it. There was one thing here. Tissue inflammation causes arginine residues in proteins like vimentin to be enzymatically converted into citrulline via citrullination. And that's one thing that is part of the pathogenesis of rheumatoid arthritis. The reason this is happening is because you killed off all your cyclic citrulline peptide. Right? You have antibodies against that. So now your tissue inflammation makes your arginine all become tissue inflammation causes arginine residues in proteins. Yeah, you end up getting arginine residues because you don't have any more of that You don't have any more of that cyclic citrullonated peptide. So really keep that tiny thing in mind. This is the kind of thing that NBME really likes to pick on. This, arginine answer choice right here. They would love to throw the same exact question scenario at you, and then the last sentence would probably be like, oh, tissue inflammation would cause what kind of residues on vimentin? And then the answer would be arginine. Right? So tissue inflammation causes arginine residues in proteins like vimentin to be enzymatically converted into citrulline. Right? So all her arginine is going to become citrulline in this patient because she doesn't have the cyclic citrullonated peptide. All right. So really significant tiny fact here. So for this kind of thing, if that was the NBME question, the arginine would be targeted and it would all become citrulline, right, in the rheumatoid arthritis patient. And this is a rheumatoid arthritis pathogenesis that you have to make sure you remember. Other than that, there really isn't anything else. This is actually a little easier than the ulcerative colitis versus Crohn was. That was really significant. There's a huge difference between the two, and there's a lot of things that can overlap between the two. But there were details for both of those guys, significant details for both diseases. Here, nothing major. You just need to remember the antibodies. You need to remember one is due to wear and tear, the other is actually autoimmune. And based off of that, if it's due to wear and tear, it's going to be better with rest. You're going to wake up okay. It's going to get worse as you keep walking and doing things. Whereas with rheumatoid, it's autoimmune. All night, it was just messing you up. And then when you started walking and moving, you get better. But you actually wake up in pain. Also, fatigue, keep in mind, for rheumatoid arthritis is going to be a big deal because these patients will have anemia of chronic disease, right? So that's going to cause the fatigue. And that's really all there is to that. So I'll stop here for now, and then in the next video, we'll go on into gout.